Okay. All right, everybody. Good morning. Thank you for joining us. This is the data integration work group. Just so everybody knows, we are still recording each of our meetings. I believe that recording has already started. We also, as a reminder, we put all of our meeting minutes and meeting recordings on the planforchildren.org website. So if you ever need to go back and take a look at what we discussed in any of our previous meetings, you can find all that information there. I believe, Tim, are you on with us yet?
I am.
Okay. Just kicking things off, if you wouldn't mind, please dropping into the chat box your name, title, organization, so that we can do that instead of going around for introductions. Let me just run through the agenda real quick. If we want to go up a little bit, Elise, because I would like to take a look at our work group goals and just kind of put that in context as we're getting to the end of our work group meetings here. But when we set the goals to review existing state plans and activities and data integration. We also had a goal of broadening state agency participation in the OPM's P20 Win initiative, and we had a couple of presentations early on related to P20 Win and crafted a recommendation around that. We also set a goal to look at key indicators and metrics of a children's behavioral health system. So what data would we need to have to know that the system is working well, and making recommendations around that. And all of this rolls up to the Behavioral Health Plan Implementation Advisory Board, as well as the 12 state department commissioners. And the reason I'm spending a little bit more time on the goals this month is because we feel like we've achieved a lot, and we feel like we're wrapping up this work group. And so we'll spend a little bit of time talking about how we want to handle the November meeting that's on the calendar. I'll let Tim do that in just a moment. So today, hopefully you got the materials. We do apologize for sending them out a little bit later than we'd like to, but there's been a lot of activity around the other work groups over the last few weeks that have taken up a lot of our time, and some of you have been a part of that. But today we want to confirm, taking a look at our behavioral health system indicators, and confirm that we're moving in the right direction there. We have identified a number of high priority metrics and indicators that we think would be meaningful for monitoring the children's behavioral health system over time, and look at a draft framework of a report. So that's going to be the bulk of our agenda. I'll turn it over to Tim Marshall to say a few additional things, and then we'll get started.
Great. Thank you. Good morning, everybody, and appreciate and thank you for all attending. Again, looks like we have about 19 or 20 folks joined, and we appreciate the consistency and the number of your folks being able to attend this. As Jeff said, we do think we're probably close to completing our work. We will give you the option. We think we could finalize the work between now and our next meeting. And then if you all want to use the next meeting to review that, or to do that electronically, but we'll defer to the group consensus on that. But essentially, we'd like to just walk through what and review everything we've discussed to date. I think our lead takeaway from this group is a lot of the work that we'd like to see accomplished is going to be on the long-term, intermediate to long-term kind of solutions. We wanted to reiterate our support and put as much weight behind the OPM P20 Win project and initiative, and get as many state departments to support that as possible. And specifically, if possible, with funding, we'd like to see that happen, so that could move along a little bit more rapidly. So we'd like to review the work that we've done today, and then again, we'll kind of outline how we're preparing the report, and then we'll let the folks on the meeting decide whether we want to move forward with the November meeting. So we're definitely feeling like we're wrapping up our work with this group, and appreciate everybody's involvement. So thank you, Jeff.
All right, Elise, if you wouldn't mind pulling up, actually I have the slides. I can pull them up myself. Let me just do that. Okay, everybody see that? Yep, okay, great. Let me just get into slide mode. Okay, so let's just jump into it. So we want to take the data elements that we've been discussing over the last couple of work group meetings. Starting in the report, we'll likely start with the data integration work group goals that we just reviewed, and also the work group process. I imagine we'll probably, in that introduction, also want to include some additional context around what's happening with the system there's been a lot of activity, particularly over the last month, and there may be some relevance of this data work kind of in that broader context of lots of legislative activity, lots of executive branch and governor's office and OPM involvement in looking at children's behavioral health. So it's likely that the report framework may start to put some of this data work into that broader context. And then we'll summarize the achievements that we made in this work group, and then dive into some of the specific recommendations. If you remember from a couple of months ago, we did craft a recommendation from this work group that was endorsed by all the people who were there at that work group, at least, around expanding and integrating with the P20 Win initiative. We heard a couple of presentations and kind of saw some examples through the 500 Familiar Faces project, for example, about the value and utility of the P20 Win initiative and how we could take some cross-system data or evaluation questions that affect the children's behavioral health system and maybe cross over to other systems and be able to work collaboratively with P20 Win to answer some of those questions over time around how our system is functioning, but also in particular how children with behavioral health needs are faring on outcomes. So that recommendation will be in the report. And then we'll get into what we've been talking about for the last couple of meetings on system indicator recommendations. And one of the things that came up in this group is that that set of data elements should really be focused on what we know to be some pain points in our system so that we can monitor how we're making progress on those areas over time. So just to give you a very concrete example, a very contemporary example, the number of children presenting to the emergency department with behavioral health needs, for example. We know that that tends to surge in the fall, and we know that it tends to surge again in the spring. And so that's something that we could, as a pain point in the system, could closely monitor over time and report on as just one of the indicators of how our system is doing, addressing the needs of young people. And we'll also, as we lay out those indicators, we are going to put them into the categories that we decided on a couple of months ago, list the indicator, and then also list what data source or where that data point would be coming from. And this just kind of visually shows you what we decided on and focuses in particularly on the major categories or buckets that we determined. I think I actually really like the buckets and categories we came up with. I think it addresses a lot of what we would want to be watching in the behavioral health system. So first of all, data indicators that get at need and prevalence and identification of needs of children with behavioral health conditions. Several indicators that the group recommended around access to behavioral health services. Some data elements on the services themselves, but then in addition to that, some data indicators on how our workforce is doing. As well as the quality of the services that are delivered and the cost of the services that are delivered. And then, of course, all of that feeds into the outcomes that we see for children and families in the behavioral health system and related systems. Let me just pause right there. Is everybody on board, kind of remembering that from previous meetings? Looks good. We're not missing anything up to this point. Tim, you're off mute.
Yeah, I just was going to encourage thumbs up or nods or any indicators that people are feeling like we're on task. I know it's kind of a early morning part of the, but also everybody's involvement has been really strong here. I love, by the way, Jeff, the visual. So thanks to you and Elise for this. It's just really fabulous.
I wish I could take credit for it, but that is 100% Elise. So thank you, Elise, for that.
Yeah, I want to echo that. The visual is awesome.
Good. Definitely. And if you see things like this, you know they didn't come from me. Yeah, it's really good. I think it does a nice job of kind of capturing what we're trying to assess here. Okay, so we can always come back to it, but let's go ahead and dive into the first category on the next slide. These are the indicators of need, prevalence, and identification that we came to that sort of repeatedly were endorsed and brought up by folks. So we talked about getting access to the youth behavior component of the Youth Risk Behavior Services Survey, which is collected at schools and an initiative that's kind of led by DPH. there are a number of individual indicators of mental health and substance use on that survey that would be really useful need and prevalence data for us to kind of go gather and routinely look at over time. So that's what the second bullet is about, items from the YRBS. And then another indicator we talked about was calls or episodes of care to mobile crisis. It's a good one to monitor. It is an interesting, we often find it to be an interesting question to say, well, if utilization of mobile crisis going up has long been considered a good thing because the alternatives are so poor, right? On the other hand, you could look at the number of kids coming into mobile crisis referrals as well. Why do we have so many kids who are calling in crisis? So it's it'll, you know, the sort of value statement behind mobile crisis calls is an interesting question, but it's something worth monitoring over time. We also identified rates of developmental screening and behavioral health screening, which can, those are data pieces or questions that we could kind of steal or borrow from a number of different sources. You can see there, CMS, CHIPRA, Washington State had a good behavioral health indicator project going. And then also that's being collected through our INC grant in a CMS. And also the group identified trauma screening prevalence in primary care as another an indicator worth watching in terms of identifying need and prevalence.
Jeff, just at a
Sure.
point too, do you want us to, I mean, there's additional data sources here, at least on the Medicaid side for both of those, the developmental screening and the behavioral health screening. Those are two procedure codes that are reimbursable under Medicaid. Did you want us to kind of chime in where those additional data sources are available?
Yeah, that'd be great. Yeah, so if we, so for developmental screening, behavioral health screening, those are ones, is that a Beacon data collection point or is that a CHN?
So it's Medicaid, so we both have the same data set, but also the other data point that you may want to consider that we talked about last time was commercial insurance under the all payer claims database, if we're just throwing things out there. Those two are routine procedure codes. So that may be another area to see if we want to look at total need and prevalence, looking at commercial as well could be an opportunity there.
Great. Yeah, that's a really, really good idea. Hopefully Elise and Leah are on the call and hope we can make a note of that, Chris, and make sure that we include that in the final iteration of the plan. I think it's a really, particularly that piece around looking across at the all claims database so that we can get a sense of prevalence across payers.
And Jeff, I wondered if, sorry, if it would make sense to insert intellectual disability.
So behavioral health need among IDDD populations, is that what you mean?
Yeah, I just noticed we had the oh, I'm sorry. Sorry. Yeah, but that might be coming later.
Okay, well, if we're missing it, if it's still a gap when we get through, then we'll definitely make a point of making note of that and capture somewhere. But I agree.
Jeff, is this where, oh, I'm sorry.
Please go ahead.
Is this where you would also include the SSTRYs for the substance abuse screenings in primary care offices?
Yeah, I think that this probably would be the place for that. Can you tell us a little bit more about that data? Because I'm not sure that one's raised.
Well, I know the new ACRA program, the old ACRA program got repurposed to a new program, and they're using the SSTRY through primary care as the primary screening for substance use in youth in the area to get treatment. So the primary care physicians in the whole state, as I understand it, are being encouraged at the very least to be doing it on all of their youth that are coming through. And that data has to be being collected somewhere because I know at least DCF is using it.
Yeah.
So they're using, she's referring to the ESPER.
Yeah.
Oh, sorry.
it's the
SSTRY was
ESPER.
the name of the program. Sorry.
Yeah.
Thank you.
And is it it's being gathered and entered into a database centrally somewhere?
Yeah, I believe
I
we have
actually,
it in Pi.
yeah, exactly.
In Pi? Okay.
Yeah, but I don't know if the primary care practices are entering the ESPER into a database.
I'm not sure about that either, but the people who are receiving it would be, I would believe.
Kathy, do you, or who is receiving it then? If it's not the primary care docs entering it, then who would be entering it somewhere?
So I'm a bit confused. We're a Stride provider. So the components of STRI, which is the replacement for ACRA, so includes using experts with youth as well as young adults. And the results of the expert, presumably, I think it still needs to be programmed, will be entered into PI. So
Okay.
that the goal is to, anybody can essentially get a substance use screening.
Okay, so we'll kind of flag it as it's kind of in that second grouping on this slide of a potentially good data source that we would just need to investigate a little bit further to see if it's available and feasible to collect. But the idea of having something more specific to substance use is missing on this list. So let's put that down and see if that's the best source of information for substance use prevalence or need.
Jeff, just to note too, there are 2 procedure codes under Medicaid as well that are specific for SBIRT, 15 and 30-minute increments for SBIRT. It's not widely utilized, but it is another data source to see the prevalence and utilization of that code, of those codes.
Okay, great. Thanks, Chris. Okay, good. So this is helpful. So that last grouping of data are also data elements that the group felt would be important, but it was a little less clear where the data was coming from. If there was a way that it was being systematically collected and entered somewhere that could be accessed for us. I do know that, there's CCMC, for example, on the second bullet collects suicide screening on all kids who enter into their system, but not all hospitals do that zero suicide initiative approach. So it is available there, but it may not be available other places. There's also rates of depression was identified by the group, the needs of special populations, and to Tim's earlier point, this could be a place where intellectually developmentally disabled youth comes in. The group also talked about prevalence or need around social determinants. I remember Chris at a previous meeting talked about an index of social deprivation that may not be a need prevalence indicator, but might be a, Chris, I can't remember the term you used. It was something essentially sort of a adjustment factor that could be looked at.
Right.
And then we also in the group talked about number of EMS runs, so calls that are made specifically for emergency department, transport to the emergency department for behavioral health concerns. So that could be an EMS data run, but it also might be captured just by looking at number of behavioral health ED visits, which is also gathered in other places. So any other questions or comments or gaps or?
Yeah, Jeff, I was thinking that this list also, although it's kind of where we're seeking the data source, it is also potentially representative of where we want to see some of these activities expanded into that are not done today. So there's a couple that come to mind. So under the positive suicide screening, I'm reminded of my conversation with Jen Jenks, who's on with Rhode Island's, and that getting schools up to speed to do that routinely so they're more comfortable with it. And then positive results are much more easy to be triaged, and giving that back to schools is a potentially great activity for us. So my point there is maybe just add schools ? After hospital and others. And then the other one I think we're missing in terms of special population, and this is a national requirement that I think we missed in the special pops, and there's huge gains of improvements for both quality life and cost savings is first episode psychosis. And we've had a lot of conversations about that, but I think we missed it on this group.
Okay, good. Yep. All good points. Any other comments or questions?
So this is Ann Smith, and I do have a question, only because I'm looking at some of the data that we are collecting for the racial, ethnic, and diversity for the schools. And I'm just wondering if there is any value or if this is the right venue for us to be looking at what is happening in terms of school level referrals to EMS and trying to find out where that is being that is being done both with and without involvement of SROs and like school social workers. Just seems like that's really important since we know that we're facing some workforce shortages there. So I don't know if that's this work group or maybe it's the other work group, but I think that there may be some crossover there in terms of our kids who are struggling with behavioral health issues in school. How do we make sure that they are being referred appropriately for care rather than just for law enforcement? And then I did see something coming in about the ACEs screening, and I think that that's important and is parallel in my mind to the social determinants of health that is also indicated we need additional data on. Thank you.
Thanks, Ann. All excellent points. So I'm just thinking about, for example, the school arrest data that comes from CSSD could be a data point to capture here. They do systematically collect the number of referrals to juvenile court that emanate from school-based incidents, and we can look at that as an indicator of if that's happening, we know that we're missing something, right, in the behavioral
Right.
system. So
Yeah.
we can talk, and then also there's lots of ways to break out referrals to mobile crisis by schools, as well as referrals to emergency departments that are coming from schools is another way to identify pain points or gaps in the system. So we will make notes of all that. And then the other thing I wanted to respond to, and to your when you first started making those comments, that part of the context of the report will also be that whenever possible, always looking at these data indicators disaggregated by race, ethnicity, and other diversity factors so that we can get at disparities in prevalence, as well as disparities in the other categories that we're going to talk about today.
Yeah, and I was
Thank you
just going to
very
add,
much. Sorry, Tim.
it's okay. I was going to say also that I think your comments are really both pertinent to this group. So making sure we collect those data points, but there's huge practice implications in there in terms of both the current ED crisis and then the work groups for both urgent care and crisis stage. So appreciate those comments, and we'll make sure those are also on the list for the other groups.
That is very much appreciated because it is very difficult to be on all three.
Yeah. I know what you mean.
We can relate to that. Okay, good. So any other final comments before we go to the next slide? All right, great. Excellent. Thank you for all that feedback. We'll make sure that we capture that in the final version. So let's go on to the next slide. If I can advance. There we go. So the second category that we talked about was access indicators. And I think we found this one to be a little bit tricky in our discussions to really zero in on what does access really mean and what measures do we have that we could truly capture access. But we did land on a set of recommended indicators. First of all, outpatient utilization rates, which you can trend over time. That's fairly easy to capture between Medicaid data points as well as data points that are available in PI. And so, yeah, you see Washington State, but that's kind of like where the idea first emanated from. But I think what we'll need to do over time is identify Connecticut-based data sources where we can get the same information. So for my standpoint, that first bullet probably is Beacon claims data as well as PI data points on outpatient utilization. We also have ED stuck rates that we've talked a lot about, and of course, over the last several weeks have become even much more prevalent in the media and also in just discussions at the Capitol. That would be both the rates of youth that present to the ED that become stuck. And just as a reminder, stuck, I believe, is defined as remaining in the emergency department 8 or more hours after being medically cleared. So we can look at that in terms of rates as well as the number of days of ED stuck as a system indicator. There's also inpatient discharge delay rates. That is another one that has been talked about a lot over the last couple of weeks. Also an indicator that's collected by the partnership, by Beacon. The bed tracking, inpatient beds available, is going to be another one that we want to closely track and monitor over time. Insurance type and what services are covered, I think, is a really important access indicator, and we're not quite sure exactly where to get that. Maybe from the insurance provider report cards as a possibility, but the idea being monitoring what is covered by insurance carriers and what's available, I think was identified by the group as being really critical for monitoring access. And then, of course, affordability of insurance in the form of deductibles and copays is another access indicator. And then finally, total number of beds and treatment slots at multiple levels of care. So again, that's kind of potentially a big one, but you can focus in on a few key levels of care and look at total number of beds and total number of treatment slots as a way to monitor whether we're moving in the right direction in terms of making behavioral services more accessible. Any questions about that first set? Okay. In terms of other ideas that the group identified, but we weren't quite clear on data sources, the group correctly identified that wait lists at various levels of care is a really important indicator, but also one that tends to be very, very elusive in accurately capturing using our existing data sources. So it's worth putting some additional thought into over time, but it's not entirely clear how best to collect that information is essentially the upshot of the group's conversation over the last couple of meetings. We also talked about frequency and intensity of treatment at levels of care. So essentially, what's the average length of stay at various levels of care? How frequently are youth being seen? Let's just use outpatient as an example. If outpatient frequency and intensity is 1 session per week, or is our system so overwhelmed that our outpatient system is scheduling many young people for every other week visits? That has implications in terms of access. We also talked about canceled appointments and no-show rates, which was another one that I think the providers in our group identified as being potentially a very elusive data point, but important nonetheless. And then finally, information on barriers to treatment. So that could include childcare issues or transportation issues or things of that nature that get in the way of access. Any other comments or questions on this slide? All right. Okay, hearing none, moving on to quality. So on this one, we talked about 4 bullets that we thought we could access information on, whether services are meeting individual needs. I think that's data that's collected in PI, referrals and connections that are made to care, the capacity, number of services, and also the capacity of services that are evidence-based is an important indicator of quality, and also fidelity to those evidence-based treatments is an important indicator of quality. And then there were a few data sources that or indicators we were looking for sources on, whether the evidence-based treatment or the services that being delivered matched the need or acuity of the child. I think it's a really, really good data point, but might be difficult to capture. One that might be a little easier to capture would be multiple episodes across intensive levels of care. So are we seeing young people that present repeatedly to emergency departments, repeatedly to mobile crisis, repeatedly to ICAPS? Because I think that tells us that services are there and being utilized, but not necessarily addressing the need, and might be instructive for identifying gaps. And then also, what's the match between the service that is being recommended versus the service that is actually being delivered? Because what we heard from our group was that sometimes the service that is recommended as being needed is not available. So another service is delivered because that's what is available. And that is an indicator of the quality of our service delivery system. questions or comments here?
Jeff, on the other, under referrals and connections to care, we do have measures on connect to care as well, post-discharge from inpatient. That's another measure. It looks like you're looking for other data sources, as well as readmission rates. I don't know if you have this under outcomes or quality indicators, but readmission rates post-inpatient is another one.
Okay, yeah, it's a good point. I think it might come up in the outcome slide, Chris, but I think you could make the case. I think you can make the case that it's an access indicator, a quality indicator, or an outcome indicator, right?
Could be quality or outcome. I would imagine that from the quality side, it's a quality of indication of post-discharge planning, but also can be an outcome for the general system.
Yeah, okay. Yeah, I think it's on the slide for outcome, but we'll get there in a minute. And either way, we'll make a note of it to make sure it's on one of those slides. Thanks.
Jeff?
Yep.
Morning. Have we talked at all here in this group about the discussion we had regarding a daily call to capture some of this data?
Oh yeah, that's a great point. Tim, do you want to speak to that? Because I know you were. So just to give the group context, if you haven't been part of those discussions, the idea Sherry's raising here is that up until the point where we have a bed tracking system or some other real-time data collection source for tracking emergency department visits and inpatient beds that are available, and maybe even PRTF and some other levels of care, the idea came up that the hospitals could have a daily phone call with one another and with those key levels of care to check in every day about the number of children that are waiting in an emergency department for an inpatient bed, for example, and the number of beds that are actually available and how long children are waiting for it. Does that generally capture it, Sherry, accurately?
Yes. Not just for data, but to also facilitate the connections for the waiting children.
I missed part. You're cutting in and out a bit on your connection. Can you say that again? All right, I think we lost her. Tim, do you want to say anything? You're on mute.
I'm sorry, it does appear that we lost her. The only thing I would say is I think that we could bring that up in the interagency work group and also with the hospital association just to check in on, seeing how that could be useful. But I think it's a good idea. I think, when we can put it into some of the short-term action items to see if that would take root.
Okay.
So
Great.
Jeff, I'm not sure if this is the same thing, but that's how we collect the ED stuff data, is a daily phone call. Is that our staff at the CTBHP do collect and contact the hospitals on a daily basis. It's reported by the hospitals to the CTBHP on a daily basis. But I'm not sure what the idea is that's over and above that.
I think when that idea came up, it was more about a daily check-in on inpatient beds or PRTF beds that are available, Chris.
Okay.
So it's very similar to what you do, but just including a couple of additional levels of care, basically.
And I think also that if there was some sort of data tracking or, like this being entered into a database type of thing, that we could capture the commercial children as well versus just a portion of the population.
Right. I think so. We're familiar with at one time there was actually multiple daily calls, which I think was one of the challenges for the EDs. So I think what we are probably need to do is to talk it all through, because I think there is value to it. It's been demonstrated there's value. The question is whether we can expand it to be inclusive of all kids and be expanded beyond just some of the current uses of it to be inclusive of, where the inpatient beds are and what those are. And again, sometimes that is happening. So again, it's hard to, but is there a way we can be sure the system does this routinely and we cover kind of a more broad universal approach with it? So I think it's really, that's the takeaway, I think, for the recommendation.
I have not been watching the chat box closely. Is there anything that people wanted to lift up that they've put in the chat? It looks like Sarah Becker has been very active in the chat box. Anything else, Sarah, you want to talk about?
No, I was
Oh.
just impressed that I had withheld till this point. I'm trying to be better in these meetings. No, no. I think that what I was sort of trying to get at is that, you know, we have models that are designed to do something, and with the idea that they then will generate their own positive outcomes. And so if there's models or levels of care out there that are compromised in meeting what they're supposed to be doing, is there a way to capture that? So I was trying to think in mobile crisis, when the volume has gone up, not so much this past year, but over time, how it keeps going up, that the ability to do the follow-up care, my opinion, gets compromised, and then you wonder what happens to these kids. And it's capturable. I don't know how accurate people are capturing it. But that's a stymieing thing on my side.
Yeah, it is definitely, I mean, it's definitely data that's there. You know, we could go back into annual reports over the years and look at how that data point has trended over time, Sarah. But yeah, it is specifically your mobile crisis follow-up rate, total number of sessions in mobile, for example, or follow-ups. But yeah, that is something that could be captured, and it might be available in other service lines too. Okay, everybody good with this slide? All right. It's just about 9:40, so we're doing fine on time. Let's skip one. No. Okay, so the next category we talked about, which was an ad that came, I think, in our second or maybe third meeting around workforce, obviously has been a significant challenge for the provider community at all levels of care. And being able to monitor how our workforce is doing, I think, is a really important way of just kind of monitoring our system as a whole. So we talked about a few data points here. Providers who meet quality and access criteria. I actually don't know a whole lot about this data indicator. Does anybody want to chime in on what quality and access criteria we were referring to? I should know that, but I can't give you much of a explanation on that one. Is this referring to some of the ECC requirements? Is that what this is in reference to? I can't recall. Tim, do you remember?
I don't. I was just
Right.
trying to.
Okay, well,
this
go ahead.
this may be, this is Bill, this may be some sort of combination of thinking about what a alternative payment model would look like related to providers meeting certain quality standards and access standards.
Okay.
That's the only thing I can think of.
Yeah, that's kind of what it sounds like to me too, like what has been ECC data indicators for a while. But yeah. Okay, so we will
Is
sort
it-
of, go ahead, please.
To Jeff and to Bill, can we get some better assessment of what that data indicator is? Because I'm concerned about making sure that we are looking somewhere here to capture where we may have opportunities to expand the workforce and yet not compromise quality, and at
Mhm.
the same time improve access or increase access. I just want to have a better sense of what that is so that we are fully exploring what the potential is to utilize that to make some recommendations.
And could you say more about the workforce component of that question and the quality?
Yes. So in some other arenas, we've been looking at how there are some administrative criteria and processes that could be relaxed, but not compromise quality, or that would not compromise quality, but that might increase access and inclusion of other providers.
When you say other provider,
So for
other
example,
providers that may not be in our system now?
or may be pending entry into our system. So for example, one of the things that we looked at specifically was like a licensing regulations that preclude your master's level clinicians from being able to enter into the workforce. We've got that intermediary LMSW, LCSW track, how that impacts on the quality of their professional training has been something that's been raised. So is that necessary? Or can that be something that is relaxed? I mean, it's relatively new, I think 2016, 2017, but is that a barrier to entry into the workforce that we could take a look at?
Got it. Thank you.
Okay, thank you. Thank you, Anne. So as we look at the other pieces on this list, I think it addresses some of what Anne was talking about also, in addition to that licensing issue that she raised. A number of indicators that get to the number of clinicians that there are in the workforce, but also their training and competencies, et cetera. So, and I think that's what we want to capture. We want to capture the number of behavioral health clinicians and other providers that are available in our workforce, but also their training and where they are and the kind of work that they're doing. So the second bullet has to do with organizations that adopt the class standards. And this is information through our System of Care Connecting to Care grant. There's been a lot of training that's taken place in providers to adopt the class standards and to develop health equity plans. So capturing that in a systematic way could be one indicator of the quality of the workforce. This adequacy of the workforce is also a little bit vague, but I think speaks to generally the number of clinicians. So there's a little bit of overlap with the next bullet. You know, do we have the right workforce available in the right places? And are they trained, and do they have the competencies? And what is our racial, ethnic, and linguistic diversity look like in comparison to the communities that are being served in the workforce? And then finally, there was a comment about the availability of prescribers, whether that's child adolescent psychiatrists, APRNs, or other prescribers that are available at multiple levels of care, emergency department, inpatient, and outpatient levels. We're not quite sure data source on that one, but I think that's there's some development that has to take place. If we feel like we've got the right indicators here, there may be some development to identifying a data source or saying there isn't currently a data source and we need to develop one.
I just had a question on that one. I think it's both the availability of prescribers in terms of prescribing, but then whether there's certain roles. It's sort of maybe dovetailing on what Anne was just saying, that where do we need MDs per se and what it is they're doing, which is huge. There's no way to undermine that, but whether there's any roles that could potentially take over for some of those duties, which would then hopefully help things like moving kids along and that type of thing. Does that make any sense? So we need people to prescribe the meds, but things like, you know, in the emergency department world, and there's a lot that goes into that. And I get that. I oversee a small AD myself, but whether there's anything there that could be relaxed a little bit to help kids get through and access what the next level of care is. Just a thought.
Okay.
Slightly different.
Yep. Other thoughts or comments? All right. So let's go to outcomes. So on outcomes, again, we're thinking, just as a reminder, we've been focusing on system level work. And so when we talk outcomes in the context of this work group, you know, for the most part, we're talking about system level outcomes. There are some child and family, of course, child and family outcomes are critically important. They're collected by nearly all the programs in the behavioral health system, but that's slightly different than what we had in mind in terms of outcomes for this group. For this group, what we're thinking about is at a systems level, you know, what is it that we're going for in terms of outcomes? How do we know that our system is working well? So with that context, a few of the ideas that have come up in this group, ED utilization rates being a really important one. Again, it's been very prominent out there. inpatient utilization rates, total inpatient bed days statewide annually, which is collected through the Medicaid system, rates of child adult depression. Again, we have ED utilization rates, but then we have some breakouts of ED department visits for mental health or for suicide, which I think is might overlap actually a bit with the first bullet. Hospital ED admissions for children and youth related to behavioral health, same story. And then we get into some things like hospital ED readmission rates on a 7 or 30-day basis, as well as the reason for the readmission. Follow-up care that's provided after an inpatient admission, which is a HEDIS measure, a very commonly collected measure across the country. Rates of disruptive behavioral disorder, which is collected by the Health Enhancement Communities Initiative. High school students who feel loved and supported is something that's collected on the kids scorecard. Protective factors and resiliency is something that other work groups have identified as being an important outcome. That's one also that we would be seeking a data source on. Rates and total days of out-of-home placement, which could be collected through the child welfare or behavioral health system or both, and broken out by age. And then finally, whether needs are being met at discharge, which is collected in the PI system. So it is a collection of some individual family level outcomes, but at a population level, if that makes sense, in terms of outcomes, but also some true system level outcomes like ED, inpatient rates, and things of that nature that speak to the system as a whole. Comments, questions?
I have a comment. I'm just a little bit concerned about the characterization that I'm hearing around the family input on the outcomes and this differentiation between the system level and family level input, because I think that there's so much to be gained by hearing from the families why, for example, looking at rates of hospital ED readmission, and it goes, what is the reason for readmission? How do we look at that though? Because when you're looking at it from what you may consider the system level and what you might learn by looking at it from the family and community perspective, I think is different, but still valuable. Because some of the readmissions from the experience that I have had with our families and in our communities is that there is not sufficient support once the child is discharged. And so for the system, that should be an indication that we need to do more around supporting families to be able to retain whatever gains might have been made. And so I guess I would just want us to be really careful and thoughtful about what data we are including and not including and why.
Great point, Ian, and as usual, much appreciated. So I think for us at this moment, collecting the data is incredibly important, and then being sure to be able to have those conversations as you articulated, and get the different perspectives about what the data actually means. I think that's always, we all sit in different positions and come at data through a different lens, and we're all strengthened by being open to hearing what those different lenses are, because we are always able to be educated by something we can't see. So it is much appreciated. And by way of a side comment, we were so pleased and surprised, but also with different perspectives on the recommendations that families made for the solving the ED crisis. And the results were very, very similar to other stakeholders in the system, but with just kind of a different perspective on them. So we have seen what you just articulated in action. So we do appreciate that.
The other thing I would add, and to your comments, is I think it'll be important in the introductory section of the report where for us to say something along the lines of the results of these data elements shouldn't just sort of like be plopped down in a report and considered in a vacuum. We should make some recommendations about how we disseminate the results that we're talking about here, and who do we invite to the table to assist us and work with us in that interpretation that you're referring to. So I think that needs to be part of the introductory element of the report, where we say it's not just spitting out data reports. How do we make sure that communities and families have access to this and can help the system interpret the results and make sense of it and translate it into meaningful recommendations. Okay. Other comments or questions on this? Oops. I guess that's it. I think that was our last slide. So that kind of covers the framework of the report. That when you see that, that's approximately how it will be laid out. We will certainly include all the comments and additional indicators and ideas that came up during today's discussion. And I think probably at this point, Tim, if you're okay with it, I'll turn it over to you next to kind of wrap it up over the last 5 minutes in terms of next steps.
Yeah, I could be wrong, but my sense was that kind of just the tone of the meeting kind of probably answered my earlier question. But we'll go forward with this anyway. So our thinking was that we would take this actual final walkthrough and pull it all together in a formal recommendations document. We were originally thinking that we could send that out before the next meeting. And then if folks felt comfortable, we didn't need the next meeting. But my sense is that we would probably prefer to have the next meeting and review that. Is there consensus on that? So let me just put it clearly out. Would people like this to be the last meeting?
I think there's a real benefit at getting together to review the
Right.
final recommendations.
Sure. Okay, that what was our assuming. We didn't also, though, we're trying to also stick to being short term on this work, but also being sure we deliver. So it is our sense that we could have the final report due for the next meeting, and our preference would be to get it out to everybody before that meeting, so you could come with suggestions and recommendations, and we would just take the meeting to do any last minute or final edits. And then following that meeting, with whatever following edits, whatever edits come forward, if there is hopefully nothing major, we could then look to submit it within a day or so of the end of that meeting. So that would be our plan. So I think that's where we'll go, Jeff. We'll pause here. We have a few minutes. Is there any last minute questions or comments on the overall? So we got into the weeds of the data elements these last couple. So, but wanted to make sure also people had an opportunity to step backwards to see the large picture, what our hope is in terms of Connecticut's moving forward on data integration across the state. Sarah, you want to comment?
Well, I guess I just had a question with each one of those outcome measures in terms of how they're being measured. So have they each been sort of vetted in terms of the implications of any one of them? So I was getting a little bit stuck on the disruptive child behavior one, and I don't know what those particular measures are. I do get worried because if we're looking at something like, and of course, I'm so sorry, but I work for mobile crisis, very familiar with that data. So we know that Black children tend to get, regardless of the behavior, Black children tend to get referred more often for disruptive types of behaviors than Latino kids or white kids. And then it makes me worried because even for the same types of histories that they might have, like depression or trauma or something like that, that they're more likely to walk away with sort of a disruptive type of behavior, type of diagnosis. And so so you have something like that, that it just means, it could mean a lot. And I'm just wondering if it tells the right message, or if it might, because I don't know about these measures, but the implications of any one of those and just sort of what it says.
Yeah, so appreciate the thought and the comment. But yeah, I think from our perspective, I think that one of the largest potential uses of the data is to, again, highlight disparities and where they're coming from. And that's a good example where one may be. And I think, as you are articulated, we've already isolated that data on a few projects and have seen that and mentioned that. So when you're able to see that, then you're able to take actions and put into strategies to try to avoid and reduce that. So that's really a good outcome of the use of the data. We don't like to see the data showing that, but when we do see it, then to develop strategies to remove it is a good one. So appreciate the comment. And we'll, again, that lens is going to be overlaid with all of these data points. Other questions, comments, thoughts, concerns? All right, seeing none, I think that's gives us about 2 or 3 minutes earlier back. So appreciate everybody's participation, and hopefully, and we'll look forward to hopefully wrapping up this work group next meeting. So appreciate everybody's continual involvement, and have a great day.
Thanks, everyone. Bye-bye.
Bye-bye.